So it's an absolute pleasure to invite Paul Mitchell to come up to give the first talk on macular degeneration, major advances in the Australian landscape. Thank you, Paul.
Thanks very much, Adrian, and thanks indeed for those very kind words. It's really a pleasure to be here, and I'd like to thank Bayer for the opportunity of speaking this morning. You know, I've lived through and worked through the period where we had no therapy effectively for AMD apart from direct laser. Then we went through PDT, and then the advent of anti-VEGF, and it's been extraordinary to see, you know, the change in what we can do. The disease, AMD, it was estimated to be about 200 million in 20 and about 300 million by 2040. And the estimates of prevalence among people under 85, up to 85, about 8.7% for any, 8% for early, and about 0.5% for late AMD. And I'm going to skip an extra slide because this one, I was looking for that slide. We'll get to it, the slide, with the global data. So the incidence of early and late AMD in the Asia-Pacific region, if you look at Singapore, and the Singapore-Malay study was one of 3 studies. These studies totaled 10,000 people in Singapore, Malays, Indians and Chinese, the 3 major ethnic groups, each about 3,300. And you can see the prevalence of late AMD in that population was 0.76%, whereas for late AMD in the Blue Mountains Eye study, and it's actually not 6.8%, it's about 1%. But, you know, overall the prevalence rates appear to be lower in Singapore than in the Blue Mountains Eye study. But the age-specific rates are not terribly different. In the Blue Mountain study, we have many more people in the much older age group. So the overall prevalence rates don't really mean a lot. If we look at risk factors for progression of neovascular AMD, you can see that, and these are data in a pooled analysis that was done by one of our group, Nicole Joachim, and published in the BJO last year. And some of it, I think, is not so meaningful, the difference between Australia, USA, or Australia and other countries, because there are differences in the studies. But one of the things that comes out is the strong age relationship. So for any AMD, it's 7% per year of age after the age of, let's say, 50. And for bilateral late AMD, really steep increase, 13% per year increase. You'll see that smoking, both past and current, are significantly associated with any AMD, but not with bilateral late, because the numbers are small. But certainly with late AMD, there's been a strong association with current smoking. And many of the studies show rates of about 2-fold higher for people who currently smoke. The main risk factor for AMD, though, is the genes. And you can see overall the combined, for one risk allele, might be CFH or ARMS2, the risk is about double and higher than that for bilateral late. But if you have at least 2 to 4 risk alleles, you can see that doubles to about 3-fold for any AMD and 12-fold for bilateral late. So late AMD, particularly bilateral, is very strongly associated with genetic risk. The other factor is the smoking issue, and you can see these are data from the CAT trial, which was the comparison between ranibizumab and bevacizumab, and you can see that in this study, the 5-year data showed that patients who were still smoking at baseline, so they're currently smoking at baseline, and we don't have data as to whether they kept smoking during the course of therapy, but you can see those people still smoking at baseline, their likelihood of having a visual acuity of 2200 or worse, in other words, blind in the US, was about 1/3, 33%, versus those people who had already quit before starting therapy, in which the likelihood of that level of vision was 20%. So in other words, not only do we see that smoking increases the likelihood of AMD about 2 to 3-fold higher, particularly neovascular AMD, people who smoke get the disease 5 to 10 years earlier, and then they have a worse outcome despite the best anti-VEGF therapy. So this is a really good argument to try to get people who've got early signs of AMD to stop. If they've got disease in one eye, but not yet in the second eye, to really urge them to stop then. And then, of course, really to, while they're having therapy, this is going to be a risk factor for a poor outcome. And actually, we can't change our parents, so we can't really change our genes. One of the things we may be able to do with the gene effect is to have a better diet, and we showed that the risk of developing neovascular AMD in data pooled from the Blue Mountains to the Rotterdam study in people who had higher intakes of zinc and lutein were actually similar in those people who had for those people who had the gene. Then if they had a high intake of lutein and zinc, their risk came down to the level of people without the gene. So you might be able to modify your genetic risk in terms of by modifying your diet. But here with smoking, we've got something we can really do something about. And we know, of course, in the Asian area, the rate of smoking is still high. Australia has really made great strides in reducing smoking at all ages, particularly young people, but also in older age. But you can see it's still important. And in my clinic, we looked at the data on the 5 to 10 years earlier. We published from the Blue Mountains Eye Study. But when I looked at my clinic population, if I saw someone who developed neovascular AMD at 70 or under, apart from PCV, which Jeremy will talk about, which is not so common here, they're always smoking. So if I see someone 69 or 70, my first question is, have you reduced the amount you're smoking? And, rather than asking, are you still smoking, or do you smoke? Because, the answer is always, oh, yeah, I smoke, but I have cut it down. So I think this is actually a really important issue. We can still do something about it. Is there an influence of ethnicity itself? You saw those overall crude rates didn't really show, they showed an apparent difference, but we showed that in Singapore there was a high prevalence of distinct drusen versus indistinct or soft drusen, so it was opposite for soft drusen. And perhaps also there might have been a difference between Northern and Southern Europe, but we've got the URI study, which is publishing data much more widely from Europe, and I think that'll give us a much better answer as to whether ethnicity is important. Overall, I think the ethnic differences are not big, and it probably is not as important as it was first initially thought. If we look at the burden of AMD and neovascular AMD, and this is looking just at Singapore, where there is this major increase, and we've lost the slide which somehow fell out, which was looking at which areas of the world AMD is going to increase the most, and it shows that in Asia, this is where the greatest increase over the next decade or 2 decades will occur. So you can see in Singapore, the number of neovascular AMD cases will increase by 42% by 2030, and the burden in Singapore alone will be, about 200 million. So we need to build and improve the capacity for treat this disease in Singapore and, of course, in other areas. This is the graph I was looking for, and you can see the projection of the increase is greatest in the Asian area of the world. And so there's going to be major strategies needed to handle that. So the MD Foundation in Australia, and let me say at the outset that we are extremely fortunate to have this group who've got together. It was initially Paul Beaumont who actually started this foundation with some, helpers, and I've been on, part of their group for almost since the beginning. One of the things, the issues they've achieved are, firstly, they've created a national voice and a dedicated patient advocate. And I can tell you, speaking to parliamentarians recently and over the years, they take much more notice of patient support organisations than they do of us as ophthalmologists. And government is really attuned to listen to patient support organisations. So they have a major advocacy role that we can't, because of our vested interests, we can't hope to achieve. And so what they've done, the MD Foundation, with advertising to the Australian population, have increased national awareness and education. For example, there's been a 40% increase in people over 50 who understand the importance of completing regular eye tests, for example, to check their macula. They were also instrumental in really pushing very hard for anti-VEGF therapies to be put on the PBS at the earliest opportunity. And as you know, we've now had anti-VEGF therapy on the PBS for 11 years, and this is really quite remarkable. And we have virtually no restrictions in using it. They've also been active in organising swift reimbursement of, and making sure that the processes we have to deal with are not onerous. And even though there's still a bit of onerousness in there, they are working hard to try to reduce that. And they've fostered a highly skilled and adaptable healthcare practitioner community. Now, they've done this together with research agencies, the industry, and the college, of course, so that this is a collaborative approach. And I think we really have got a good scene now in Australia. And other countries have looked at this and said, wow, how can we emulate it? For example, just the awareness. These are data showing, and they've done the standard polling that the politicians depend on, like News Poll and others, to see what is the proportion of people in Australia who've heard of or are aware of the disease macular degeneration. And you can see over the last decade or so, from 2007 to 2011, they've increased it, and it continues to increase. So currently, the awareness among people 50 or older of the macular degeneration disease has gone up from 58% of the population to 92%. So that's amazing. And they're now working on trying to get Australians to understand what are the symptoms that might indicate a sudden development of AMD, in other words, distortion of straight lines, a dark patch in your vision, or sudden worsening of the vision in one eye. Those three things, to try and get that in people's heads that actually this is pathology, it's probably macular degeneration, you need to be seen straight away. And this is not glasses, this is not cataract, you actually need to be seen quickly. And I think this is a very important issue. In terms of the AMD experience from the patient perspective, and this is a survey that was reported in Graphies, and you can see, so this is not necessarily Australia, 300 people. Not that many were aware that neovascular AMD is a chronic disease. They were aware of the consequences, that was high, and they were able to name the disease. These are people who had the disease, but they weren't actually, less than half could name the treatment they were on. Not so many were afraid of side effects because they obviously knew that it was pretty good. But actually, 2/3 assumed it was about to stop or was going to stop in the near future. In other words, rather than this was more or less lifelong. And so, many of them still had a major need to attend appointments with a carer. And so this is one of the impediments and barriers to receipt of optimal therapy, which I'll talk about shortly. Real world evidence is where the outcomes of therapy are looked at in different countries and different communities to see what really happens outside after the clinical trials are finished and the drug becomes available. And these are data from the AURA study in Europe. Now, we all know that the treatment in the UK, despite their best efforts in the NHS, is often suboptimal. But you can see the UK absolutely beat the pack. Compared with the Netherlands, France, Germany, look at Italy. They basically got down to the baseline level by 1 year, and of course well below that afterwards. So these were data using Lucentis, anti-VEGF therapy commencing between 2009 and 2011. So this was early days with Lucentis, but over 2 years, most people lost their gain in vision over time. These are more recent data now from France using Eylea, and it's a pretty big sample. You can see it's about 500 people, and you can see overall with Eylea there was a good gain of about 6 to 7 letters. That was maintained at 12 months, and you can see with an average 6 injections, which for real world data is pretty good. You can see in the second year, patients lost half of that benefit, maybe more than half that benefit, because the number of injections dropped to between 2.4 and 3. It depended whether they had a loading dose in the beginning. You can see those people who got a loading dose, they're the ones in blue. They had an average 6.6 injections in the first year. That's 3 loading, and then approximately bi-monthly. And then in the second year, where they could go to the Eylea label of modified quarterly dosing, they didn't receive it. You can see only 2.4 to 3 in the people who had the original loading dose. So the problem here is they lost the ball. They basically took their foot off the accelerator, and of course people will lose vision. This is a relentless disease, and unless you keep treating people aggressively, you'll lose it. And so clearly this is under treatment in year 2. How do we compare, how these compared with the published Australian data? Now, there are a lot of Australian data. These are data from 1,200 patients on Mark Gilley's FRB registry. Now, one argument could be that these are from retina specialists. These are maybe the top of the crop, but you can see what can be achieved. So you can see with a mean starting vision of 55 letters, about 624, the average got up to about 618, about 6 letter gain, and then over the next 5 to 6 years, you can see numbers are dropping a bit by 5 years, and down to 6 years, not so many, and 7. But there's a remarkable retention of vision over that period. What's the reason? Really simple. There's basically 5 injections a year from the first year on. In the first year, there were 6 injections on average. In the second year, the number of injections has been kept essentially the same. And that is the secret. You can see if you do that, you maintain vision remarkably. And this is my experience in my clinic, and it is amazingly consistent. So I think here we're seeing really probably almost the best results in the world. The blue line shows that actually over time there's an improvement in the vision that people present with. And that's also important. We know people are now presenting earlier, particularly the second eye. We pick up the second eye straight away. But despite that, we're actually achieving extremely good results over time. We need long-term data from this cohort and from others in Australia. But these are very encouraging data indeed. And this is Australia. I think we can be proud that we do, with the PBS and the lack of any restrictions and the system we have, which allows both drugs, virtually no restrictions, we have an extremely good outcome. But there are impediments to access. This is a paper that we did with Robin and others from Melbourne and the MD Foundation, showing that in regional areas, the number of eye care practitioners, if it was low, that was associated with lower access. Regions with an older population, overall lower outcomes, and remote locations. So these are the usual suspects. And so that is really important. But, we still know that for many people, undertreatment is relatively common. And I think in our clinics, we need to identify and address the barriers to achieving adequate injection therapy. So these are some of the barriers. So firstly, even though we've got the drug-free, there are significant out-of-pocket costs. And for some people, this is a reason to stop therapy or to not come so frequently. And I think we need to address that. There's the issue of the tyranny of distance in Australia, and even within a place like Sydney or Melbourne, where travel across the city is so difficult with heavy traffic. Travel is a major issue. The burden on carers who have to accompany people. So that's why we really need to make use of community transport and all of the other ways that people can get there without having to bring a carer with them. We also, many people with AMD are older, they're having their knee replacements, they've got lots of comorbidities, and so we've got to work around that to make sure they can still get their eye treatment. Many of them, of course, maybe 60% to 2/3 over time will need second eye treatment, and that means they need bilateral treatment. That's a real problem if you're treating just one eye at a time. So we now move very frequently to bilateral same-day therapy, and that really helps a lot of people to maintain it. If they've got other problems going on, people get injection fatigue. This is where SmartSight, the program enrolling people in SmartSight, is a brilliant maneuver because they are so attuned to the importance of keeping on going. So I would recommend everyone gets enrolled in the program. And that the patient education is key to making sure they understand that this is long-term treatment, that we really need to, address these issues. And I think, we need to be proactive. In my practice, we use treat and extend to establish a conservative interval. Then we keep this. We plan ahead with people. We try to get a schedule of visits over the next 6-12 months. So we tell them what's coming up. We don't want to hit them with a surprise and they say, oh, by the way, I'm going overseas for 6 months. We have an information sheet and we tell people, if you're going to go overseas, if you're going to be absent, please let us know. We actually send people text reminders. I think everyone does that now, but we keep at people if they don't come. I've got it worked out, so that once we've got a good interval for people, we alternate fast visits where they don't have a VAC and OCT, so they can get through really fast, every second one, unless, of course, there's any symptoms. We know that for some people, morning, most of them want the morning, but some people, their carer's working, so we can fit in some late afternoon ones. And, of course, we keep hammering them with sheets and information to try and get them to keep up coming. But SmartSight is really helpful. Once they've done that course or been enrolled, it really helps. Now, these are the data from the VIEW trial, which was fixed dosing in year 1, 3 monthly injections, and then every 8 weeks. Year 2 was modified quarterly, so they had to have injections at least every 12 weeks. And you can see for the FRB data, people are actually achieving that. And these are data from the VIEW study showing that for 2Q8, that's extending to 8 weekly in year 1 and then the modified quarterly in the second year, they got just as good results as giving it monthly. So this is the appropriate therapy for the vast majority of people. The number of injections in VIEW was 7 in year 1. You'll see in that recent real-world evidence, with a loading dose, they got 6.6. So really, most people are maintaining that. And the number of injections in the second year in view on the 2Q8 was 4.2. So you need at least 4 injections. And you saw in the FRB, people are actually giving an average of 5, and they're getting extremely good outcomes with that. What proportion of people could be maintained on 12 weekly? About half. So half can be maintained, but that means the other half need more frequent than 12 weekly. And there's some who need even every 4 to 6 weeks because they have persistent fluid. And persistent intraretinal fluid is critical. This is the extension. It wasn't done in all of you patients. You can see for the 3rd and 4th years, and that's the last 2 bits on the graph, there was a loss of about 3 letters, but overall the gains were largely maintained, and that was with an average here of about 6 per year. In Altair, which was an ILEA study, they showed also that when you extend people in a treat and extend regimen, rather than extending by 2 weeks at a time, you could go by 4 weeks at a time. And overall, there were really no differences. So this means that this treatment is pretty robust, and it means that you can actually jump from 8 to 12 or from 6, to 10 if you wish. But I still think you want to be guided by those early months as to whether the intraretinal fluid and hemorrhage resolves very quickly. PCV, and Jemmy will speak to you soon about PCV, and I'm just going to introduce it by saying this is a disease in which there are abnormal choroidal vascular networks ending in polyps. It's differentiated from neovascular AMD and RIP subtypes, but genetically the disease is relatively similar to typical neovascular AMD. The frequency in Japan, shown on the right, just as a typical Asian population, is higher for PCV than typical neovascular AMD. And although these data here is an estimate of about 10% in Caucasian populations, we know it probably is higher than that because most people don't do ICG to actually pick this. We can talk later on about whether ICG is really important. In the PLANET study, and Jamie will go into this in much more detail, aflibercept was able to be used as monotherapy in the vast majority. You can see by year 1, at the end of year 1, less than 15% of people needed rescue PDT, using a step criteria for the need for rescue. And overall, patients who didn't need rescue, they gained about 11 or 12 letters. Those who did need rescue, you can see overall the gains were lower. And you can see we can also see evidence of the new vessel very well on OCTA, shown on the bottom right. And I'm going to talk about OCTA and neovascular AMD tomorrow. And this is just a sample of a typical patient who's got very good vision, but a bit of subretinal fluid that's persistent. We know may not be so important in the long run. And it's got persistent choroidal new vessels shown on the OCTA. So in summary, we know that the global prevalence and burden of AMD will increase. Anti-VEGF therapy with a proactive regimen is a recommended standard of care. Real-world studies show the importance of doing this and of treating adequately. We need to avoid under-treatment. And certainly we need to look in individual patients at what the barriers to achieving under-treatment are. Recent studies show that anti-VEGF therapy can be extended well beyond 8 weeks for many people. The average is probably about 10, but probably half of people can be treated with 12 weekly or more. PCV, probably about 10% of the people we see, is becoming prevalent in all countries, and we're probably underdiagnosing it, but the data show that aflibercept will be able to treat the vast majority of patients with PCV just as effectively as it can with typical neovascular AMD. Thanks very much.